utilized to have a very meaningful discussion around neurospinal tumors, right from the basic concepts like pathology, diagnostics, and up to the surgical management. Baxter Advanced Surgery is proud to be associated with Dr. Krish Sridhar and MGM Healthcare, and I would like to take an honor to introduce Chief Coordinator for today's webinar, that is Dr. Krish Sridhar. Sir qualified for the National Board of Neurosurgery, and after his graduation in 1982, his neurosurgery training was under the pioneer Neurosurgeons of India, Professor B. Ramamurthy, and he also got a chance to work with Professor Ghazi Yassergil, Professor Mohit Sami, and Dr. K. Sugita. After taking multiple assignments, in 2011, he became the Director of Institute of Neurosciences and Spinal Disorders at the Global Hospital, Chennai, setting up a Neurosciences department. Sir has got several publications in both international and national peer-reviewed journals, has edited textbook of neurosurgery and operative neurosurgery, and has contributed several chapters to neurosurgical books. He conducted regular hands-on course in microneurosurgery, training young neurosurgeons. He also has fellows in neuro-oncology, vascular neurosurgery, and spine surgery who trained with him. He has been awarded the Best Doctor Award by Dr. MGR Medical University, Chennai, and honored by Dr. Rajaratnam Oration Medal by IMA and Dr. Dhyanand Rao Oration by Andhra Pradesh Neuroscientists Association. And I invite Dr. K. Sridhar to please take a session from here.
Thank you, Suneet. That was quite long. But thank you very much, and thank you to Baxter for supporting this Tumor Thursdays webinar series. So this week we are going to look at intraventricular tumors. Last month we did gliomas, and that was went very well. And I think we had a lot of lovely interaction. Now, today we'll be looking at intraventricular tumors. We've got a very distinguished panel, not only of speakers, but of very seasoned surgeons as moderators. And I'm sure that we are going to have a lovely interactive session ahead. I'll just introduce the moderators to you, but none of them need real introduction. Professor N. Muthukumar, currently the head of Department of Neurosurgery at Madurai Devadas Multispeciality Hospital, is an alumni and then retired as Professor of Neurosurgery at the Madurai Medical College. He is the Honorary Secretary of the Neurological Society of India, and he is a well-known figure in many conferences and gives many lectures and has written many chapters. He has also been the convener and co-editor of the Progress of Clinical Neurosciences, which is brought out by the Neurological Society of India. So welcome, Dr. Muthukumar, for being here. Professor Manas Panigrahi is a dynamic chairperson of the Department of Neurosurgery of KIMS, Hyderabad. He actually is also the chairman of the Board of Education of the Neurological Society of India. He is extremely an academic person who educates many young neurosurgeons and is continuing to do that. And thank you, Dr. Manas, for being here with us today. Professor Dilip Panickar, Professor and Head of Neurosurgery, Aster Medicity, Cochin, is a senior neurosurgeon. He is a member of the Executive Committee of the Neurological Society of India and the current convener of the CME program of the Neurological Society of India and editor of the Progress in Clinical Neurosciences. He's an alumni of the Sri Chitra Institute of Medical Sciences. His interest is in skull base, tumors, functional neurosurgery, and many other neurosurgical techniques which very often young neurosurgeons are not adept at, and he's a lovely teacher and excellent advisor and mentor for youngsters. So I will hand over the sessions to them, but before I do, I will just also like to thank the speakers from all over the country and Japan as well. Welcome to Professor Tadashi Watanabe for being here. It's a little late in the evening for you, but thank you for being here. And thank you, Dr. Mathew, Dr. Krishna Prabhu, Dr. Sanjay, and Dr. Sandip also for being here. Now, before we proceed further, This is the agenda for today, and I'm sure that you'll agree that this is all very interesting and some things which all of us see every day in our lives. But I think I won't go into this, but I would just like to highlight that in December we are organizing the first Asian CNS virtual international conference on the 13th and 14th of December. It's going to be a virtual convention center, including 2 lecture halls, a poster hall, exhibition center, etc. With all everything that you get in a conference, you'll be seeing here. So this is getting organized right now, and once the website is up and everything is ready, I'm sure all of you will be very, very excited about what we're going to do. This is in December, 13th and 14th of December. We're planning it in such a way that the timing will be so that it's convenient for both Eastern countries as well as the Western countries, so that people can speak and join in across the world. The other thing, academic activity that we're doing is for the nurses. We had the second Asian Congress of Neuronursing on the 1st of February at Chennai, and now we are going to organize the third ACNN Asian Congress of Neuronursing in November 2020. It's going to be an online web conference, so please support your nurses' education. The registration is free, and they can send their abstracts and topics to the email acnn2020@gmail.com. This is being run basically by nurses across Asia and Southeast Asia. And I would like all surgeons, senior surgeons, to propagate this and encourage your nurses, neuro nurses, to join in and come and be part of this Asian Congress of Neuronursing. So over to the moderators. Thank you very much, and please enjoy this academic feast.
So good evening. Let's, without any further ado, let's go on to the first lecture. The first lecture will be on approach and management of lateral ventricular tumors. This will be delivered by Dr. Mathew Abraham, who is the professor and HOD of neurosurgery at Citronal Institute, Trivandrum. He has wide areas of interest with special interest in neuro-oncology and epilepsy surgery. Dr. Mathew, you're on, please. Dr. Mathew? Dr. Mathew, we are not able to hear your voice.
Am I audible now?
Mathew?
Yeah, you're audible.
You're again muted, I think. Mathew, you're muted.
Am I audible now?
Yes, you're now audible.
Yes.
You can...
Okay. First of all, let me thank Dr. Sridhar for giving me this opportunity, and Baxter for all the logistics. Now, surgery for lateral ventricular tumor is my topic for today. This is a relevant anatomy of the ventricles and the lateral ventricles and the tumors. All the structures that line the ventricle, as well as the all those that participate within the ventricle, also contribute to ventricular tumors. There is the ependyma for the SIGA. The septum gives rise to the central neurocytomas. The choroid plexus to the papillomas and the carcinomas. The thalamus to thalamic gliomas, and the corpus callosum gives rise to some tumors which project into the ventricle. First of all, let me talk about the approaches to the ventricle. I've tried to make a logical classification of the approaches. First of all, the first group is regarding the philosophy of approach. That is, those which actually follow the pattern of an EVD. The second one is regarding the midline approaches. The third is regarding the superior parietal lobule approach, which is an approach to the trigon, as well as the approach as a temporal horn. When it comes to the middle frontal gyrus approach and the inferior parietal lobule approach, the philosophy is basically an expanded Cocker's point approach or a Keen's point approach. The midline approach through the callosum is familiar to all. You can have an anterior, a far anterior, and a posterior approach. And the superior parietal lobule approach, which may be paramedian, it may be transsulcal, or it may be directly through the parenchyma. The temporal horn approaches will be dealt with later. So this is basically the middle frontal gyrus approach. The approach is nothing but an extension of the Cocker's point EVD. It has a lot of advantages. There is the main advantages are there is no risk of damage to the veins. The mild obliquity the approach gives facilitates the three-dimensional view towards the lesion. It can be expanded anteriorly as much as you want, but posterior expansion is a little difficult. There are no major arterial territories. It's a vascular watershed zone, so you cannot produce a big infarct by going through there. However, the disadvantages of this approach are that there can be frontal dysfunction, particularly on the left side. It has limited posterior reach, and there is poor access as far as the opposite frontal horn is concerned. So this is the one of the cases. You can see a central neurocytoma with a right frontal horn extension. This is the trajectory through which this lesion has been removed. This is a fairly straightforward approach, and everybody is familiar to the Cocker's approach, so it's a very quickly available approach. The next approach, which follows the pattern of an EVD, is the inferior parietal lobule approach. You can see this is the EVD points, the Fraser and the Keen. And if you draw a line, this forms a horizontal line parallel to the base of the skull. And if you make a craniotomy here, you can access the trigon from whatever point along this line. If you're more anterior, it's convenient to access the occipital horn. And if you're more posterior, you can get a better anterior access. The main advantages are the short trajectory. The approach is the shortest trajectory. You can access the trigon as well as the temporal and occipital horns. It is expandable. Vascular injury is unlikely if you are reasonably careful. However, the disadvantages are it is relatively contraindicated on the left side. You can injure an abnormally placed vein of Labe, and you can occasionally injure the angular artery. But you have to remember it is not a watershed zone, and an injury to the artery can result in a large, extensive infarct. It's the inferior parietal lobule that you go through in this approach. Although I said it's relatively contraindicated on the left side, in scenarios like this where you have an extensive edema on the scene on the left side, and you're having a calcified central neurocytoma sitting here, we have gone through an inferior parietal lobule and still approach and still has achieved reasonable decompression. This is a very versatile approach, and only thing you have to be used to the anatomy and the trajectory. We are all familiar with the midline approach, the transcallosal approach. The midline approach, needless to say, you can go into any trajectory. You can go into the opposite side. You can go into the same side. You can go into in between the fornix into the third ventricle and even into the suprasellar region and even into the cellar. You can connect it to the anterior interhemispheric approach also. Now, this is actually a variant of this interhemispheric approach. This is the far anterior interhemispheric approach, which I employ it once in a while when you have a lot of blind territory under the callosum. The disadvantage of this approach from above is that just adjacent to the callosum, you will have a large blind area. But if you use an anterior approach, far anterior approach, you can still visualize that part of the lesion which is sticking to the undersurface. Then you have a posterior transcallosal approach. Not a very popular approach. I very seldom use it because of the large number of venous adhesions. However, it can have its own advantages. The obliquity of an anterior approach can cover most of the region that we desire from the posterior approach also. So this is basically a scan of an anterior, of an interhemispheric approach. You find this lesion here. This is a relatively small lesion with an attachment to the callosum, a central neurocytoma. It has been approached to the midline, and you've got a reasonable excision. But this is not the case in most of the many of the intraventricular lesions. You can see this extensive central neurocytoma, which has extension into the left frontal horn, as well as most to the left side, as well as bilateral. Here you can see we have got a reasonable removal, good removal if you see, but we can see that the fornices are still, we cannot see. And you can see a small area here, a blind area. This is actually the true disadvantage of the midline approach, is that you have a small blind area adjacent to the callosum here. But it really doesn't matter. Most of these residual lesions does not change the prognosis of the patient. The superior parietal lobule approach is an approach for the left side. It is very good to have it image guided. It is a deep approach. There is no significant venous compromise. It is an arterial watershed. They are unlikely to produce any major infarct. It is expandable in every direction. However, it produces parietal lobe dysfunction and can produce some degree of visual field compromise. So here is a patient whom we have gone through this approach. You can find this thalamic tumor, which is sitting here on the left side. We have gone through this approach and we have removed this lesion. It's a fairly effective approach, but only thing, the depth of the approach sometimes can be a little disturbing, particularly the beginners. Last but not the least, I must mention this approach actually by Professor R.C. Mishra. There is a transinsular approach to the thalamus. Although strictly speaking, it's not an intraventricular, it is not an intraventricular approach. However, this is one of the few approaches which can be used for a lateral thalamus. Let it be the lateral posterior, lateral dorsal, or ventral posterior lateral nuclei. You can actually use the trans-sylvian approach. This requires meticulous dissection of the sylvian so that you get a trajectory posterior to the posterior limb of the internal capsule. It will traverse a region of the retrolendiform capsule, but it spares the sublendiform capsule. So this is a patient. You see this tumor is located in the lateral part of the thalamus. There is no way you can really approach it from the midline. And if you go from the trigone, you still have to traverse through the pulvinar to reach it. But here you can access, you can see we have accesses through the sylvian, through the insula, and we have removed it. So this is a fairly good approach as far as the lateral part of the thalamus is concerned. These are the approaches to the temporal horn. I think this itself is a very major topic, and maybe we may tackle it in some other sitting later. This is my personal series with intraventricular tumors. I have 242 lateral ventricular lesions, excluding the temporal horn lesions, of which the dominating one has been the thalamic gliomas, 116 of them, and central neurocytoma, 44 cases. What I will now do is I will just briefly go into the surgical nuances of central neurocytoma and thalamic glioma, which form the bulk of all intraventricular tumors. So this is a patient with central neurocytoma. You can see the central neurocytoma is reasonably alarming in size, but it's a fairly simple lesion to tackle from a true surgical point of view. Its planes are actually fair. It is between the two layers of the septum. Here it is having some adhesion to the lateral wall of the ventricle, as well as it's going down into maybe into the third ventricle and to the base of the forebrain. I shall show a short video how we tackle this lesion. If you see, a good midline approach is one of the basic resources of every neurosurgeon. And the crux of this approach, crux of any surgery, let it be a sebaceous, let it be a ganglion, let it be the interhemispheric, is to get the right plane, to be in the exact right plane. So you must consider the medial frontal as eloquent areas and preserve them meticulously. If you see, I have gone to the left side. I'm opening the left side of the callosum. The lesion is located in the left ventricle, left side lateral ventricle. We can see this lesion is has presented itself. It was that part which is lying adjacent to the callosum which has come out first. You should follow a specific pattern as far as the tumor is concerned. It must be a central, gradually expanding central decompression pattern that you must follow. That is the same for any form of lesion which is lying in a region where you do not have full access. Let it be a pituitary tumor, any other tumors which you do not have a full total access around. The pattern to be followed is a central, gradually expanding central decompression pattern and a final removal of the remaining region. So I'm using a Q site to decompress. Here I am trying to preserve this white tissue is actually the remnant of the septum, the intraventricular septum. My baselines is to protect at least one of the fornices and ensure that I don't cause any injury to the internal cerebral vein, nor injure the lateral wall of the ventricle, where you will find the genu of the corpus callosum, genu of the internal capsule reaching. This has been completed, the lesion has been totally removed, and this EVD is a lifesaver. You can see this is the post-op scan of the same patient. You can see that even the lower part of the lesion has been removed, and we have removed a little portion of the callosum here, and otherwise it looks fine. Now, when it comes to the thalamic lesion, thalamic tumors, as oncosurgeons, we should not be looking at the thalamus as a single entity. We should take our cues from the movement disorder surgeons and see the thalamus as a complex entity. This anterior part of the thalamus is the limbic thalamus, while the medial thalamus is closely associated with the prefrontal cortex, with the frontobasal regions, the frontal eye field, and these sort of regions. While in the lateral thalamus, you find there are specific relay nuclei on the lateral thalamus. Let it be the ventral anterior, ventral lateral, ventral intermediate, ventral posterolateral, and ventral posteromedial, as well as the geniculate bodies are specific nuclei. And the pulvinar is an association area of the parietal cortex. You see this Y-shaped structure in between. That is the internal medullary lamina, which is the condensation, which is actually the condensation of the brainstem as it comes into the thalamus. And you have a set of intramedullary, intralaminar nuclei within. This is actually the continuation of the ascending reticular activation system, and it has a and it complements with the reticular nucleus which lies on the lateral aspect of this zone, and these two give reverberating circuits to the cortex in a ratio up-down ratio 1:10, and it keeps the cortex alive. And you cannot breach this area, and if you breach it, the whole cortex leaves off. So any approach to this zone has to respect this anatomy. So you cannot breach this this Y-shaped area. Plus, although the classic presentation, neurological presentation of a thalamic glioma is the hemianesthesia, we seldom see that in real practice. That is because most of the lesions are located in the pulvinar or in the geniculate bodies, medial or anterior. Those which are present in this lateral part present very early with major deficits and usually do not come as candidates for open surgery. Most of these lesions are tackled either with a biopsy and radiation, while those in the pulvinar, the medial thalamus and the anterior thalamus come with large size lesions and will produce obstructive symptoms. So when you approach a lesion, you can't approach a lateral lesion from here. Almost the entire area is actually almost non-operable. Most of the surgeries will be done here, here, and here, and you can't breach the internal medullary lamina. So you have to choose your approach so that you will not breach this area. And there is little scope for a second look surgery. So this has to be a definitive procedure at the onset. So I'll just show you the procedure of excision of a pulvinar lesion. You can see a lesion lying here, producing obstructive hydrocephalus. You can see the capsule is intact. It's producing discharge to the third ventricle as well as producing hydrocephalus. So this is an inferior parietal lobule approach. You don't require a big cortical opening. This lesion is on the right side. This is being deepened. This is an ultra short approach to the trigon. You will reach the trigon within 3 to 4 centimeters from here when there is hydrocephalus. You can see it looks white. Most of the thalamic lesions are covered by a white layer of tissue. And you may suddenly think that you have not reached on a wrong area. But when you are able to cut through that area, you will quickly see the tumor. This is a grade 3 lesion and eminently suckable as well as fusible. Most of the thalamic lesions are highly vascular, although there can be avascular lesions also. Some of them may be pilocytic astrocytomas. The crux of a open surgery for a thalamic glioma is in the completeness of removal. You really can't leave anything behind. You can't poke a tiger with an umbrella. If you leave any significant residual tumor, it will bleed. The wounded glioma syndrome will come, and most often you cannot pull the patient out. So the crux of this thing is to make a complete removal. And very often, if your plane is good, if you can differentiate the tissue, you will get some form of a pseudo plane with the remaining normal thalamus. So you can see we have already removed most of the lesion, and we have got some form of a plane where there is normal tissue seen all around. I use very minimal surgical within the brain, within the ventricle, where most often this surgical will be removed after hemostasis is achieved. But maybe because this was a very high-grade lesion, they have left something behind, and an EVD again is essential. So this was a post-op scan of this patient. You can see that the lesion seems to have removed. The radiotherapy department refused to give radiation. They convinced the patient, but the things are not often very rosy. After 1.5 years, this patient had a recurrence. He underwent a re-excision, radiation. He developed dystonias in the post-operative period and is still on a wheelchair. Thank you for patient listening.
Thank you, Dr. Mathew. There was a really wonderful, short and exposition of a very difficult topic. And if I open the topic for discussion, there's only one question right now. I think you made a very pertinent regarding thalamic glioma, because in thalamic glioma, you said that about wooden glioma syndrome, where there's no question of taking a biopsy or doing a partial resection, because it is going to react very violently. So that's a very important take-home message for all of us. And are there any specific approaches to the pulvinar? Would you like to?
Yeah. The pulvinar is best approach from a inferior parietal lobule approach. Okay. And pulvinar tumors may form the bulk of most of thalamic gliomas. And the inferior parietal lobule approach is perhaps the shortest and best approach towards it.
So what about the post-op?
If it's on the left side, you can use the superior parietal lobule approach, but it is deeper and still a very fair approach to the pulvinar.
And initially in your discussion, you made a very rightly pointed out in midline approaches, there are certain blind spots in the lateral corners of the ventricles where a portion of the tumor can be left behind. Am I right?
Yeah. There is always a small blind spot laterally. There are ways of catching that blind spot. You can remove more of the callosum. The bulk of the callosum can be reduced and reach it. Or you can go for a low anterior approach where you can actually see it. But very often this small residual does not matter. And you can actually follow up. If it's a central neurocytoma, you can follow it up for years and still nothing will happen. So extreme maneuvers to catch this residual tumor may not be worthwhile.
So what are your specific indications for a trans-sylvian, trans-insular approach to a thalamic lesion, which Dr.
Yeah. This is a very good approach actually by our R.C. Mishra sir. Thing is, that is perhaps only a real approach available for the lateral thalamus. Okay. All other approaches to the lateral thalamus are through some part of the other normal thalamus. So you can open in the lateral thalamic lesions usually present with hemiparesis, with dystonias, hemisensory loss. So they present as very small lesions. So the number of cases you may have to tackle is actually very low. That is why this approach is not that popular. But whenever there is a lateral thing, particularly the cystic chronic presentation lesions can be tackled through the spine sylvian approach. But the thing is, you have to meticulously open the sylvian up to the origin of the angular artery. Otherwise, you'll end in the capsule. You have to go really posterior and get a trajectory which will take it to the lateral aspect.
There are two more questions in the chat box. There's one is regarding the use of an endoscope as an adjunct to find the blind areas in the lateral ventricle, which we just talked about. Do you use an angled endoscope? So,
I have tried using it. Okay. First of all, I always use an drain, EVD drain, and endoscope. There is some degree of mismatch at the end of your surgery. I'm being frank. The definition in 3D that you get from a microscopic approach cannot match the 3D that you get from an endoscope at that stage. Particularly, these are very oozy lesions, and at that stage, I may limit my removal to what I can see under a microscope.
Apart from the fact that even if you use an endoscope, if you are able to see the lesion with an endoscope in one blind corner, we may not be able to reach it, isn't it?
Yeah, You may trigger a new problem and may not be able to control it. So once you have got an 90% excision of a tumor, thalamic tumors will not produce much problems. Basically, the septal lesions or the lesions which arise from the callosum which will cause the problem. If you get 90% decompression, the general mood of the surgery is to come out, rather than go ahead and try to create a new bleed which will destroy your whole story.
Absolutely right. So you mentioned that invariably you leave behind a EVD at the end of surgery for all ventricular tumors.
Yeah, always. And if the EVD is flowing, I'm very happy. If the EVD is not flowing, I always get another scan.
Okay, what's the role of
these thalamic gliomas are very poor lesions to go back again. Virtually, you can never save a thalamic glioma going back again, is my experience, because when you go back, you will cross into the internal medullary lamina region and will produce very significant hemispheric dysfunction.
Do you use DTI? DTI before you plan surgery for?
Yeah, I use DTI, but it has not changed most of the time. It has not changed the procedure, because actually clinically you know whether you can take out a thalamic glioma. If you are having a pulvinar lesion with hemiparesis, it's actually a non-removable lesion because it's going beyond your pulvinar zone.
Okay.
The thalamus should be seen as an anterior, medial, lateral zones, and one lesion going from one zone to the other is actually virtually unremovable.
That's a beautiful concept which we nicely elucidated. Are there any questions from any other panelists, speakers?
There is one more question in the chat box from Dr. Devigan, I think. The percentage of complications and the common complications that you have seen.
The percentage of malignant glioma and low-grade glioma in your series among the thalamic gliomas.
Yeah. The complication, the mortality rate is not insignificant. I've had 6 mortalities for thalamic glioma in the early postoperative period. So approximately you can expect a mortality of 5 to 6%. Around 5% mortality can be expected. Most of them from rebleeds. Once you get a rebleed, the patient is gone. Even if you re-evacuate, the patient never comes out. So minor rebleeds which flow through the EVD is okay. So the thalamic glioma, particularly the high-grade ones, are among the most dangerous lesions to tackle.
Most thalamic gliomas are usually high grades, isn't it? You rarely, if ever, see any low.
Majority are high grade. But you will get even
pilocytic astrocytomas with excision of extent of excision, whether endoscopic biopsy, septostomy, and shunt followed by adjuvant therapy gives a better prognosis, or excision and adjuvant therapy gives a better prognosis?
Definitely, excision gives a totally different outcome. Excision gives a totally different outcome. Most of the patients who undergo biopsy and radiation very soon have obstructed ventricles, horns. They very rapidly deteriorate. Excision patients, at least for 1.5, their prognosis seems to be somewhat better than that of the lobar high-grade gliomas. Even glioblastomas seem to survive above 1 year.
Dr. Mathew, Somebody has asked about the role of 5-ALA in thalamic glioma.
I have not used it. I have
You have
not
not-
used it. I think I have no experience with ALA in this one.
Any of the other
not
panelists have any experience with 5-ALA in thalamic gliomas?
Yes, not 5-ALA, but with yellow fluorescence we have experience. And yellow fluorescence usually helps for identifying the normal margin also, not with 5-ALA, because that is very expensive, but if you use yellow fluorescence.
There's one more question regarding the transgyral versus transinsular. That's what I think. Transinsular.
Yeah.
What is the morbidity?
Transinsular excision is a technically demanding one. There is no question. Going to the insula and the posterior most region requires very fine meticulous patient dissection. But once you reach the posterior insula, it's a very clean. Once you have reached there, it's an excellent approach. The transgyral approach is always brought with some degree of morbidity. However, a reasonably safe approach. You can go through the small region in this one, through the operculum and reach the same region. On the right side, on the left side, it is more difficult.
There are no more questions. I think, Sridhar, it's time Dilip takes over and.
Yeah.
Okay. Thank you, Mathew.
Thank you, Dr. Muthukumar.
Wonderful. Really enjoyed it.
Thank you, Dr. Muthukumar. And thank you, Mathew. That was a nice, crisp talk. Really enjoyed it. May I now call upon the next speaker, Dr. Krishna Prabhu. Dr. Krishna Prabhu is a professor and head of Unit 1 Neurosurgery at CMC Vellore, and he's an alumnus from CMC Vellore. He is an excellent surgeon with a lot of experience with spinal and cranial surgery. He has organized a number of meetings and has a huge number of publications to his credit. Dr. Krishna Prabhu will be talking about the microsurgical approaches to colloid cysts. Dr. Krishna Prabhu.
Thank you, Panickar. Yeah, thank you, Panickar, for introducing me. Thanks, Dr. Sridhar, for giving me an opportunity to speak. And thanks to Baxter for organizing this. So, I will be talking about the colloid cyst, the microsurgical management. And see, basically, all of us know that colloid cyst is a benign congenital epithelial line cyst. And it arises in the anterior third ventricle. It's attached to the roof of floor, fornix, or the choroid plexus. The problem is these lesions wedge into the foramen of Monroe and then resulting in hydrocephalus. They can vary from small few millimeters to several centimeters. Very small ones may be asymptomatic, but the larger ones definitely cause problems. These are rare in children, but usually it's seen between third and fourth decade, it's commonly seen. And 40 to 50% are asymptomatic, but those who present with symptoms have severe features of raised intracranial pressure. Some of them even come with posturing, and some can even have a sudden death. So the problem is because the lesions are obstruct the foramen of Monroe, causing a rapid onset of hydrocephalus, herniation, and death. So the features they present with features of raised ICP, headache, drop attacks, or coma, or even death. They can even present with impaired memory, some form of visual impairment. They usually have papilledema, and they can even have gait anomalies. Now, this has been reported almost since 1858, and the first surgery for colloid cysts was done way back in 1921. And the first endoscopic surgery was done in 1983, so it's been a long time, long way back. Now, the symptomatic colloid cysts, which is the symptomatic colloid cyst? Younger patients who have colloid cysts are more symptomatic. Patients who present with headache are symptomatic. Those who have large cysts, that is about 13 millimeter size, are quite symptomatic. Those who have large ventricles are symptomatic. Those who have a T2 weighted MRI scan showing hyperintensity, they are also symptomatic. So the young patients, those who present with headache, those who have large cysts, those who have hydrocephalus, those patients who have T2 weighted hyperintensity, they are all very symptomatic and they need to be addressed immediately. The two tests that are commonly done is a CT brain or MRI brain. I think MRI brain gives a better three-dimensional picture. A routine CT in a non-enhancing CT scan is in 2/3 of the patients, you could it will be just a hyperdense lesion in the anterior third ventricle obstructing the foramen of Monroe. Maybe sometimes it's hypodense or isodense. And this density is correlated inversely with the hydration state. Calcification and hemorrhage are rare and no contrast enhancement of the lesion is seen. So it's in a plain CT scan can give you a diagnosis most of the time. An MRI in a T1 weighted images, the signal of a colloid cyst correlates with the cholesterol concentration. 2/3 are hyperintense, whereas 1/3 are isointense. While on a T2 weighted image, majority are isointense to the brain. About 25% are mixed, and they can have even a black hole effect. The flare image does not, the signal is not suppressed, and there are no restriction on DWS scans. This is a typical MRI picture. You can see that in a T1 scan, it's hyperintense. In a T2 scan, you can see a mixed signal intensity with profound hypointensity. And you can see in a flare image, it does not show any suppression, and DWS scan does not show any, there's no restriction. Again, another image. So there is T1 shows hyperintense lesion, and the contrast image does not show any enhanced uptake. And most patients will have a large ventricle with the transependymal seepage, which showing periventricular lucency. So the options that are available, surgical options that are available, basically falls into 5 categories: a transcallosal approach, or a transcortical approach, and a microsurgical excision, an endoscopic fenestration and excision, and stereotachy aspiration and insertion of shunts. Now, the last two approaches I'm not going to discuss because you know they have a limited role. So I will be talking mainly on the microsurgical approach. That's mainly the transcallosal and the transcortical approach. So those who are symptomatic, those who have ventriculomegaly, those who have progressive size of the lesion, those patients who have a cyst size larger than 7 millimeter and symptomatic, we will go for surgery. Now, one thing that we all should know is where does the colloid cyst lie? Now, in a sagittal MRI, there are 3 zones that needs to be looked into. The zone 1 is from the lamina terminalis, going backwards towards, going posteriorly to a vertical line drawn from the mammillary body and tangential to the massa intermedia. So this is zone 1. Zone 2 is from posterior border of zone 1 all the way up posterior to the rostral apex of midbrain tegmentum at the inlet of the cerebral aqueduct. Zone 3 is anything behind this, and it is the posterior limit of the third ventricle. It obstructs the cerebral aqueduct. So any lesion, any colloid cyst that is in the zone 1 and zone 3 are likely to cause hydrocephalus earlier than a lesion in the zone 2. So zone 1 and zone 2 are risk zones that we need to be aware. So always you must look at the MRI sagittal image to find out where exactly is the colloid cyst, in which zone does it lie. Another thing is the colloid cyst risk score. You are all familiar with it. Basically, you have 5 parameters. You look at the age, less than 65, means you get a 1 point. Headache, you get a 1 point. An axial diameter more than 7 millimeter, you get a 1 point. Flare hyperintensity, you get a 1 point. And risk zone, if the lesion is in risk zone, you get a 1 point. So you got a maximum of 5. As the scores improve, the patient's symptoms also higher, and patient needs a surgery much earlier than the lowest colloid cyst risk score. So once you have decided to do surgery, you should consider craniotomy and microsurgical excision. Why? Any lesion that is more than 2 centimeters may compromise and adhere to the fornix and also to the roof of third ventricle. And this will be more safely removed using microscopic bimanual dissection, which is very important. And if you find in the image, if the lesion is hard and cheesy, then you must go for a microscopic excision, a bimanual excision. Between the transcortical and transcallosal, I have more favor for transcallosal, but transcortical can also be done very well. So the position that we routinely use is a semi-sitting position, which everybody is familiar with it. You can either make a linear incision, or you can even make a box-shaped incision, whichever you're comfortable with. You make a small craniotomy centered around the coronal suture, 2/3 anterior to coronal suture, 1/3 posterior to the coronal suture. You make a small craniotomy, and you must make sure that you expose the superior sagittal sinus. Otherwise, a transcallosal approach will become very difficult. So the superior sagittal sinus must be exposed. So it's the same routine intrahemispheric approach. So you do a small craniotomy, you make a medial-based dural flap, you identify any bridging veins. Do not take any bridging veins. You go through intrahemispheric approach and you enter into the ventricle. And once you enter the ventricle, this is the picture that you are likely to see, showing the colloid cyst, thalamus tight vein, choroid plexus, and anterior and septal vein. So this is what you see when you enter the ventricle, a typical colloid cyst obstructing the foramina monro. This is the choroid plexus, this is the thalamus tight vein. You must all be very familiar with anatomy in this region. So you must know where the colloid cyst is, where the thalamus, where the septum. So only if you're familiar with it, you will not cause damage. If you're unfamiliar, you may end up in causing deficits. This is a typical typical patient who presented with acute hydrocephalus. Patient came in a posturing state to the ER, and you find a large colloid cyst which shows a mixed signal intensity. So we decided to go through the approach. This one we approached through the transcallosal approach. So we made a small craniotomy. We made a medial-based dural flap, and you identify the pericallosal vessels. You identify the corpus callosum. I always keep two small cotton ball anteriorly and posteriorly, so that way you don't have to apply a retraction at tension. So you just need to keep the minimal retraction to keep the brain away. If you don't keep these cotton balls, you may have to use a larger force, and that may result in a contusion and cause problems. So you need to make a small callosotomy. The advantage of doing transcallosal approaches, you can go into either ventricle, whichever you want to, right or left. So which is an advantage. So once you enter, you identify the lesion in the foramina monro, you nick the capsule, and you empty the content. This patient had a mixed content. It was a jelly and also a firm substance. So we have to gently, use suction, and I usually use one suction, keep it at low power. You don't need to use a high suction power at all. You try to debulk the content. Entire content should be debulked before you attempt to do any capsular dissection. Most of the time, the materials can be just sucked out, but in this patient, we had to use a dissector to scoop it out. Once you have taken the contents and the cyst is collapsed, then you can peel the wall away, and cyst wall can be peeled away from the surrounding structures, and it can be excised totally. Then you inspect the third ventricle, make sure there is no blood clots, so the thalamus tight vein is preserved. And normally I think sometimes if there is some amount of bleeding, I leave a ventricular drain, and then you can come out and remove the drain within 1 or 2 days once there is no blood in the ventricles. This is another patient we approached, a similar lesion, large lesion causing hydrocephalus. This one we wanted to go through a transcortical approach. So we went through a right-sided transcortical approach. We identify the sulci between the superior and middle frontal gyrus, use the sulci. We use a tubular retractor that is being used it was designed by Dr. Arichoko, my boss. This tubular retractor is of 19 millimeter in diameter. It is made by us. So you went into enter the ventricle, similar to the transcallosal approach. Now you identify the cyst, you nick the cyst, empty the contents completely. When you are releasing the contents of the colloid cyst, try and not let it go into ventricles because that can cause a chemical meningitis. So try and avoid, and even if it does, please irrigate copiously and make sure patient does not get chemical meningitis in the post-operative period. So once you have taken the contents out, the cyst wall can be now seen. Then it's much easy to peel off the capsule. That is the fornix. We are preserving it. One of the big advantages of microsurgical dissection is this. Because we use a short handle instruments, you're closer to it. So our dissection is precise and you can go out for a gross total excision of the cyst wall. This patient had actually the cyst wall was, very large and the cyst wall was quite large. So we had to meticulously, slowly peel away the capsule, preserving all the vital structures surrounding it. In the end, we were able to completely take away the entire capsule, which was lying within the third ventricle. A part of the choroid plexus was attached to the lesion. So just cauterize the lesion and we excise the capsule completely. We leave behind a drain and then we come out. In the last 15 years in our unit, we had a total of 76 patients we have done. In all of them, we have done a gross total excision. We had one patient who had a transient hemiparesis, that is through a transcallosal approach. We had 4 patients who had transient memory disturbances. 2 patients developed venous infarction, both were transcallosal. One of them needed a reoperation for decompressive connectomy for a venous infarction. We had 3 infections and no mortality. Now, between microsurgery versus endoscopic excision, now, if you look at the data, metadata available in the literature, in a microsurgical excision, you can get almost 98% of the patient, you can get a complete excision, as compared to neuroendoscopic excision, where only 58% can get a complete excision. So the advantage of microscopic excision is that you get a greater extent of resection, lower rate of recurrence, and lower rate of reoperation. The similar rates of mortality and shunt dependency must been same between both the groups. The advantage of endoscopy, if you look at it, is that the overall complication rate is lower, but that can be explained with the fact that they are not removing completely on all the patients. So that explains why they have a lower rate of complications. Between the transcortical and transcortical, yes, it can be done, but you must know that you are removing a normal part of the brain, and in about 8 to 25%, you can't get even a seizure, post-operative seizures. It gives access to only one ventricle, but there is less chance of venous infarction. It can be done, especially if the ventricles are large. If the ventricles are small, then you are forced to go to a transcallosal approach. Advantage is it gives access to both ventricles, and ventricle size does not matter. But the problem is that you could get venous infarction if you damage the veins, and that has to be avoided. And if you keep prolonged retraction on the lobe, you can also get weakness. And the problem with the endoscopic approach is that you need a lot of experience, and cyst location and the degree of distension of the third ventricle roof make cause problems if you use a rigid endoscope. So you have to use a flexible endoscope, which is not freely available yet, and traction on the adhering the capsule may lead to bleeding. You can cause damage to more fornix, and not always you can excise the colloid cyst completely. And you must also know that coagulation of the capsule is not equivalent to total excision. So it is not, many a time people decompress the cyst and they excise part of the wall and then the coagulate. That is not equivalent to total excision because even that can cause a recurrence and reoperation may require in the end. In summary, as I mentioned, indications are raised ACP, hydrocephalus, cyst larger than 7 mm if symptomatic, larger than 30 mm even if asymptomatic, and lesions in zone 1 and zone 3. And if it's a T2 hyperintense, go for surgery at the earliest. And surgery, my personal choice is microscopic excision. It's a gold standard because of good excision rates, less recurrence. It is just a routine microsurgical skill and instruments. All neurosurgeons can do it. You must attempt a gross total excision, but don't hesitate to leave behind a small capsule on the vein or on the parietal plexus if you are uncomfortable. And the end result should be that you should get excision, but not at the expense of any deficit. Endoscopy, yes, still evolving. It still has less overall morbidity. Maybe it might evolve further for more future. But currently, it is still not as gold standard as the microsurgical excision. Thank you very much.
Thank you, Dr. Krishna Prabhu. That was a very nice exposition of the standard conventional microsurgical techniques for excision of colloid cyst. But I must say there are few procedures that are as elegant as a nice, clean microsurgical excision of a colloid cyst. It's a very satisfying procedure with excellent results. A few questions that I have, first of all. One is, you mentioned both the transcortical and the transcallosal approaches. When would you select which approach? Under what circumstances? Or do you have a personal preference between the two?
Okay, I would say you can do a transcortical approach if the ventricles are large. If the ventricles are small, transcortical approach is not recommended. It's not a good way to do it. You have to go through a transcallosal approach. Yeah. Personally, I did initially my career, I did both transcortical as a transcallosal, but in the last 7-8 years, I've switched to completely transcallosal, and I'm quite comfortable with it, whether ventricles large or it's small. Personally, I go for transcallosal because I don't have to go through a lot of normal brain, dissect through it. You're straight intrahemispheric, you're straight on in a short span, you're on to callosum, you're on to ventricle quickly. My personal choice, transcallosal, but I have no problem against transcortical if somebody goes through it, especially if you use a tubular retractor because it protects all your surrounding brain and you're straight into ventricle. If you don't have a tubular retractor, then you're forced to use multiple retractors, hand retractors, so all sorts of things. It's a messy surgery. Yeah. So, but I have nothing against transcortical if you're doing it.
Yeah, the tubular retractor actually makes the transcortical approach very straightforward. It's a straight path, and the retractor protects the surrounding white matter. Do you do a septostomy when you get into the ventricle for all cases, or do you reserve it only for some?
I don't. I always inspect opposite ventricle. Even if I remove, I just inspect opposite ventricle and make sure that there is no clot or there is CSF flows freely from both sides.
Okay.
I don't do routine septostomy, but I try to see the outcome.
Okay. A few questions from the audience. One question is, where exactly to incise the corpus callosum? Any landmark?
Okay. I told you the craniotomy is the first crux. Yeah. You must make a craniotomy 2/3 anterior and 1/3 posterior to coronal suture. That is one. So I would say just stay anterior to coronal suture. Anterior to coronal suture. You just go on the straight vertical plane. You will enter into exact, almost closer to foramen Monroe.
That is yes, I completely agree.
The tendency is for people that I've seen is that they keep the microscope and towards their tummy and they go more posterior. Then they find that actually the foramen Monroe is way anterior, and then so you just keep the microscope. That's why the position is important. A semi-sitting position, a straight microscope vertically downward, you will be straight on the foramen Monroe.
Yeah, that is a fallacy where you lose the verticality and you end up angling posteriorly and you enter the ventricle at a slightly odd point. That makes that inconvenience.
You make a larger colostomy, then it becomes a little messy after that.
Dr. Devigan wants to know, what is the rate of regrowth of incompletely removed cyst wall?
well, I don't know what the literature is, but it does grow back. I don't know the exact percentage.
Yeah, that's one of the problems, that you leave behind cyst wall, and over time it does tend to, there is a high probability that it will grow back. Another practical question was about the EVD. When you leave the EVD in place, when do you remove it?
Usually, if the CSF clears in 24 to 40 hours, we remove it.
Okay.
You don't need, because these are not like tumors much larger, like intraventricular tumors, which can cause a tumor bed bleeding and oozing. These are actually clean surgeries. You just keep 1 day, 24 hours, most of the time they're out.
The indications for surgery in colloid cysts are very often very, very clear and straightforward. You have a patient who comes in with a sizable cyst, the large ventricle, symptomatic, and there's no debate about the surgery. But once in a while, you end up with a situation where you have, say, a young person who comes in with intermittent headache, where historically is very, very classical, very typical of an intermittent rise in pressure. And imaging shows you the small cyst located at the foramen of Monro with no ventricular megaly. That's always a dilemma. At least for me, it's a dilemma. What would you advise under such circumstances?
It's a good question. Actually, that's what I mentioned. So, if you see, the foramen of Monro is 7 millimeter in diameter. So, if you have a lesion 7 millimeter and above, there is no question of, even if there is some symptoms, I would not wait.
Yeah.
If I have to err between this waiting and operation, I would go for surgical excision. But I don't want to have a situation patient coming to my ER middle of the night posturing. If
Absolutely.
there is a dilemma, I would err, go for surgery and take it out.
Right.
Would any of the,
yeah, I completely. Would any of the other panelists have an opinion on this?
Dilip, sorry. Okay. After this, there are about 4 or 5 questions in the question answer box.
Okay.
Yeah.
Okay.
Can I comment something?
Yeah.
There's a paper on incidence of seizures comparing transcallosal and transcortical route, and the paper said that the incidence of seizure is similar, 18 to 20%, like early post-op seizure, whether you do transcortical or transcallosal. It's only the persistent seizures is around 6 to 8%, as you told, in transcortical. In transcallosal, you do not get persistent seizures. So, but early onset post-op seizure, there has been no difference. So, if you take into account that, is there any real advantage of transcallosal over transcortical?
I think the biggest, my personal concern transcallosal, because I don't want to go through normal brain. It's just transcallosal is a minimal callosotomy and you're not doing anything. That isn't, but I don't think it's a big, because these brains are not, you can't do a transcortical approach and not a big deficit you're going to get. In fact, if the venous infarction chances are much less. A young neurosurgeon starting his career, I would say go transcortical, because you are better off doing transcortical than transcallosal. Maybe once you are comfortable, you are experienced enough, I would say go for transcallosal.
I think, Manas, the point about the transcallosal is that it's easy to look at both ventricles. I think that's the biggest advantage of the transcallosal, where in a transcortical you won't be able to do that.
Yeah.
Can I ask a question, Sridhar?
Of course. Dilip is the boss.
Yes, please. Go ahead.
Dr. Krishna Prabhu, you just mentioned in your slide that if the lesion is 13 millimeters or so, even if the patient is asymptomatic, this is what I understood. You will go ahead and operate. Am I right?
Yes.
So you mean to say that its size is the only criterion on which you base it, or you may base it on the age also? For example, if there's a 11 millimeter lesion in a 25-year-old and 11 millimeter or the 12 millimeter lesion in a 65-year-old, do you think the lesion will be the same or it will differ?
No, it's not the same. A 65, 11, it's different from 11, 65 and a 25-year-old boy. Well, 11 millimeter lesion, if symptomatic, yes. No question of waiting. 11 millimeter, non-symptomatic old man, yes, I may keep my fingers crossed and ask him to hold on.
Okay. Thank you.
Dilip, there are some questions in the
Yeah, I'm just going through them. One was any experience with the head in a lateral position for gravity-assisted retraction.
I have not done it and I have not felt the need for it, but I've not done it.
Okay. Yeah, it sometimes helps. Maybe less useful for a colloid cyst, which is a fairly straightforward surgery, but some of the lateral ventricular tumors, I think the lateral ventricle with the ipsilateral side down can give you some gravity assist to reduce the retraction into the ventricle. Another question is, how many times have you had to do a VP shunt after gross total resection of colloid cyst?
I think we did, mentioned here, we did 3 patients, I've not put here, three patients we have done shunt.
Yeah.
They had features of NPH, 2 of them.
Yeah. Okay. And the last question here is, is there any condition of the patient where you do a bilateral shunt and leave him alone?
We have not done it, I suppose.
Yeah.
Don't know.
Probably the only situation I can think of is if you have a very moribund patient who comes in.
But even then, you need a GA.
Even
You need a
then,
GA to do a shunt.
Agreed. I guess it's probably more straightforward to go in and remove the cyst and give the patient a chance at recovery.
Dilip, there is one more question on opinion about choroid plexus cauterization.
Where was that? I'm shuttling between the chat box and the question answer box.
Yeah. No, this is in the Q&A box. What is your opinion on choroid plexus cauterization?
You don't have to cauterize in most of the patients, but some patients you can see the lesions, the choroid plexus supplying it or attached to it. You may have to cauterize it. We have not had any issue with it. You can go ahead and cauterize. It's not a problem. It's not an issue. But don't take the vein. Thalamus-tied vein, don't take it. You have to preserve it. Choroid plexus, yes, you can.
Dilip?
In fact, the choroid plexus is probably one of the reasons why you can sometimes get a bit of bleeding, especially when you don't coagulate and divide the choroid plexus, that the attachment on the blind side, as you roll the cyst away towards you. That sometimes, if a bit of unwarranted tugging can cause a bit of bleeding on your blind side. So it's always wise to coagulate and divide the choroid plexus as you go through. Anyway.
Do you routinely... Hello? Dilip, am I audible?
Yeah, you are.
Dr. Krishna Prabhu, do you routinely test for do any memory tests following transcallosal approach? What's the incidence of memory deficits after transcallosal?
We had 4 patients who had a transient memory disturbance, but they improved. By 10 to 14 days, they will come back to normal. But 4 we had transient memory disturbance. 4 out of 7.
Can I?
Yes, please.
Can I answer that question actually? After a colloid cyst excision, most of the time there is a memory improvement. That is obvious on neuropsychological testing.
I think, Muthu, can we move on if there are no more questions?
Yeah. So thank you, Dr. Krishna Prabhu, for this excellent talk. And I will hand over to Dr. Manas, who will go ahead with the next speaker. Thank you.
Yeah, good evening. Thank you, Dr. Sridhar, for organizing a topic which is dear for everybody. That's why we have a lot of participants who are listening to this and questions also. The next talk is on endoscopic excision of colloid cyst, and actually it will be like a debate with Dr. Prabhu showed a microscopic excision, and this will be given by Professor Watanabe from Nagoya, Japan. He is the head of the neurosurgery at the Red Cross Hospital, Nagoya. He has the unique combination of being trained in India and Japan. So many of the Indian neurosurgeons know him. And he's the chief of endoscopic neuro department. And I heard that in Japan, if somebody is a chief of endoscopy department, they cannot operate anything with microscope. They have to do with endoscope. I don't know, Professor Watanabe can clarify that. So he's, with this few introduction, I like Professor Watanabe to give his opinion on endoscopic surgery of the colloid cyst.
Professor Watanabe, please unmute yourself. You're muted.
Okay, thank you for the introducing me, Dr. Professor Manas, and thank you for giving me an opportunity to make a presentation here. Today, my topics is endoscopic surgery for cholecystectomy in third ventricle, and I'm going to talk about the technical aspect of this approach. Okay. Okay. So, introduction. To access the cerebral ventricle, victim of brain tissue is unavoidable, and the transcortical approach or transcallosal approach performed by microscopic surgery for intraventricular lesions such as cholecyst. And the most important benefit of endoscopic surgery are wide surgical view with a sufficient illumination even in deep area through a minimum corridor. And in addition, manipulation underwater, we call it wet field technique, is available only in endoscopic surgery. And these benefits allowed us to perform endoscopic resection of the deep-seated brain tumor, including intraventricular tumors, and with a minimum invasive corridor using a transparent cylinder. As surgical corridor is limited by a cylinder, so ingenuity of surgical technique or tools are required to achieve the complete surgery. I will present our experience of endoscopic cylinder approach for cholecyst at the third ventricle. And here is my surgical tools for transparent cylinder. This is a transparent test up needle. The outer diameter is 5 millimeters, which I made. And there's the thin transparent sheath. The diameter is 6, and the middle size, this is 10 millimeter, and a larger one. This one is called view side, made in USA. So when we use a two-hand technique. By manual manipulation, we use this 12 millimeter view sight. And then these are surgical tools for hemostasis. And this is suction monopolar. And also this one is a very thin, malleable bipolar forceps. So we can use this forceps even inside of this 10 millimeter sheath.
The slides are not changed.
Oh.
Yeah, now you can see the slide.
Can you see? Surgical tools?
Yeah, the previous slide actually, now you can explain again. Because...
Okay, can you see this bipolar forceps? Okay.
No, previous. No, this is surgical tools. Now bipolar forceps.
Oh, okay. So I will wait for a moment. Can you see?
Yes.
Okay. So these are tools for hemostasis, suction monopolar and bipolar, very thin one. And also this bipolar is malleable and very thin, so I can use it inside the sheath, okay? And dissectors. Because the corridor is very narrow, we need this kind of dissectors. So this one is rotating dissectors by stools. So by rotating the shaft, the tip will move like this. So we can do a meticulous manipulation with this instrument. And also we use this kind of very thin monoshaft forceps, and we have developed this kind of malleable dissectors. And so when we use a two-hand technique, we use a scope holder, a floor standing scope holder, Mitaka Union. And the ventricle is filled with irrigating artificial CSF and inflate ventricle using a thin catheter inside a cylinder. And we can do a wet field surgery. And hemostasis is done by both monopolar coagulators or suction monopolar. Monopolar coagulation is only in dry field, but bipolar coagulation we can do in wet or dry both. I will show you later. And this is the movie. When I using transparent dilators. So after opening the 3 centimeter trephination, and we use the acrylic transparent test tap needle, and then we dilate the trajectory by a transparent dilator by monitoring by endoscope, and use transparent sheaths, neuroport or a view site. And instead of narrow corridor inside, surgeon can move the cylinder toward to the object where dissection is required. And the assistant will keep the depth of the sheath by holding the sheath and keep free for the angle. So thus the surgeon can move the sheath simultaneously with his hand. Okay. This is the case report, 41-year-old male who developed a diplopia and blood vision, and since 1 month before the surgery. And MRI revealed a hydrocephalus with a cystic lesion at third ventricle like this. And this is the MRI, P2, and enhanced MRI showed slight enhancement of the cyst wall. This is 3D image created from the data from the T1 image. So we have done the surgery from left frontal horn puncture. I show you the video. This is the transparent test tap needle, and now we reach to the ventricle, and we can confirm the cyst. And then now I am observing the cyst wall and plexus. And the fornix is stretched and fanning on the cyst wall. So I am trying to dissect the fornix, but the adhesion was so tough. So now I have done a puncture of the cyst, and so evacuating the content of the cyst, I am cutting the tough cyst wall with 2 hands. Now it is a dry field. I'm using scissors and suction with 2 hands. And the inflation again, so wet field surgery. I'm dissecting the anteroceptor vein from the cyst wall, but it was a little bit difficult. Always this kind of big color cyst, the adhesion is very tough. So I always leave the cyst wall on the structure. So I'm going to leave the every normal structure, including anteroceptor vein. The cyst wall was very thick in this case. So now in the wet field surgery, I am doing bipolar coagulation. Yeah. So even in irrigating water, bipolar coagulation is available. And then I'm cutting the cyst wall at the third ventricle side. and coagulation again, preserving the older vein. So I'm cutting the cyst wall at the third ventricle with the monoshaft scissors and suction. And this is the dry field, and you can see the enlarged from a Monroe and mammillary bodies. And of course, the coagulation at the dry field is of course available. And now I'm grabbing the cyst wall of the third ventricle side and going to cut this membrane. And I am going to make the two big hole at this cystic lesion. Also, the membrane is tough, so I'm cutting this membrane using a scissor and action. Okay, then okay, final piece of the cyst wall I am cutting. Now you can see the two big hole, and you can see the aqueduct beyond this hole and posterior commissure. I'm coagulating the wall of the cyst. And this is the roof of the third ventricle. And choroid plexus, and the vein is preserved on the cyst wall. Okay. This is the final view of the surgery. And this is the trajectory made by a 12 millimeter cylinder. And confirming the hemostasis, we finished the surgery. And the trajectory is closed by Surgicel and the fibrin glue. And if possible, I sometimes suture the arachnoid membrane with the 5-0 suture. And the surface is covered by a Surgicel and fibrin glue to avoid postoperative tension hygroma, subdural hygroma. Okay, this is postoperative MRI. Sorry, and this is pre-op, and this is 3 months postoperative MRI. And this is 9 months post-MRI. Actually, in my experience, if you leave some amount of cyst wall, it will disappear in several months. Okay, thank you for your attention. Okay.
Thank you, Dr. Watanabe, for a beautiful demonstration of endoscopic excision of colloid cyst and with minute technical details. I have few questions.
Yes.
Yeah. Do you do microscopic colloid cyst excision, or you do only endoscopic excision?
I only do endoscope. Actually,
endoscope.
I not only in colloid cyst, intraventricular tumors or deep-seated brain lesion, I do endoscopic cylinder surgery. So my experience is more than 120 cases for endoscopic cylinder surgery. So I choose the endoscopic surgery.
So this is like endoscopic assisted, or you do pure endoscopy with the, I was not clear in the presentation. Is it...
I'm not sure about the terminology, but I just observe by a rigid endoscope, 0 degree, 30 degree, and I do by manual manipulation.
Okay, so it is through the tubular retractor, the same size what you use for a microscopic surgery.
No, I think, you know, I use a 10 millimeter or 12 millimeters. So I think 12 millimeter, maybe microsurgery is available, but I think it a little bit small. Maybe you feel small. But using endoscope, it is not so small. Okay.
Manas, there are
So
some questions.
what are the indications for microscopic surgery in colloid cyst?
Sorry?
When do you refer a patient for a microscopic surgery?
Actually, now I have exoscope. It's a kind of microscope. So I exchange exoscope and microscope. So actually, in my hospital now, Aichi Medical University, I don't use microscope. I only use exoscope and my endoscope. Okay. Exoscope is just like a microscope, but heads-up surgery. I see the monitor in 3D glass with a 3D glass. So now totally shifted to heads-up. Heads-up surgery. So I don't use a microscope now.
Okay. So there was one question where it's a contraindication for endoscope approach.
Contraindication.
So, for endoscopic approach.
For colloid cyst or intraventricular tumor?
Colloid cyst and intraventricular both. When you will not do an endoscope approach? That's what is one question. I don't know the name. It's coming as V, but
once you have used to use the endoscope with the special technique and the special tools, I think it is just a way to do a surgery. So I mean, in my opinion, there is no contraindication for colloid cyst.
do you use external ventricular drain after endoscopic excision?
No, I don't. No, I don't.
There's another question where they've asked, would a low GCS be a limiting factor for endoscopic colloid cyst removal?
Low GCS?
Yeah, if the patient comes in a bad condition,
yes,
whether you'll do a microscope or endoscopic excision.
I choose endoscope. No question.
Dr. Watanabe, can I ask you a question?
Yeah, can I? Dr. Muthukumar, Dr. Dilip, Dr. Sridhar can ask him.
Yeah. In patients with small ventricles,
yes.
Do you find the difficulty in maneuvering the guide tube? Do you see any possibility of bruising of the walls?
Yeah, that's a good question. I use a navigation system. I use the silver balls on the endoscope. So endoscope can be, the needle. And then we cover the transparent sheath and then go. So, I can do a first step with the guide of endoscope and the navigation both.
But once you get the 10 millimeter sheath inside,
yes,
the operating sheath inside, if you have small ventricles, when you maneuver the guide tube, would that cause a damage to the walls of the ventricle?
Yes, for a small ventricle, it is, the angle is limited. So, but I think it is the same as a microscope.
Can I ask a question, Manas?
Yes, please.
Dr. Watanabe, the tubular retractor which you use, the neuroport, has a diameter of 12 millimeters. So it's almost similar to the tubular retractor which Dr. Krishna Prabhu showed us. So basically the access port is similar both in microsurgery and endoscopic surgery.
Yes.
So what exactly is the advantage of endoscopic surgery vis-a-vis microscopic surgery?
Yeah, good question. Good.
Exercise is same.
Yeah. You know, the viewing angle is much wider for endoscope. So you can see the structure widely. So you can recognize the orientation inside the ventricle. You can see any veins and the fornix and the colon plexus with a wide viewing angle. And also another advantage is underwater surgery is available. If you inflate the artificial CSF, the space is widened by water pressure. So, and also you can irrigate the small bleeding. Big, much bleeding, we have to do a hemostasis with a dry field, but small bleeding, we can wash with irrigation. So we can make a good surgical field in underwater. That is another.
Last question by Muthukumar is over. Yeah, can I ask just the last question by Dr. Sai Kiran has asked? What is the cost of a Sugita retractor versus a pneumatic holder retractor?
That is not a Sugita holder. That is
what is the cost of Sugita versus this pneumatic holder retractor?
Yeah, a little bit expensive. That is pneumatic, not electric. Only pneumatic.
How many times Sugita? 10 times?
Sorry.
How is it 10 times more expensive than the Sugita retractor, the pneumatic holder?
You know, you are talking about the Sugita head holder?
Yes, yes.
I don't know how much the Sugita head holder, but the uniarm, the pneumatic holder is about 40,000 US dollar.
Okay.
40,000 US dollar, yeah.
Okay. So thank you, Dr. Watanabe, for the demonstration of endoscopic technique, and thank you, Dr. Sridhar. You can go on with the next lecture.
Yes, we'll move on to the next lecture by Dr. Sanjay Behari, who will be talking to us on management of posterior third ventricular tumors. Dr. Sanjay Behari needs no introduction. He is the professor and HOD of neurosurgery at GBGI Lucknow. He is one of the most sought after speakers in Indian neurosurgery. Dr. Sanjay Behari, please.
Thank you so much. Thank you so much for inviting me. It's an honor and privilege. Okay. So I'd like to talk about approaches to the posterior third ventricular region. So what exactly is posterior third ventricle? It is the part of the third ventricle which is posterior to the massa intermedia of the thalamus and the mammillary body. So all tumors which are situated posterior to that form the posterior third ventricle. So when we are actually evaluating a patient with a posterior third ventricular tumor, what are the things that we are looking for? One of them is the enhancement characteristic. So is the tumor enhancing? A non-enhancing tumor could be either a dermoid or sometimes also an epidermoid teratoma or even a glioma. And therefore you would kind of get and a very uniformly enhancing tumor could be a germinoma. You look at invasiveness and what type of invasiveness is important. If the invasiveness is too much on one side, then it's important because then you choose your approach according to that. If the invasiveness is it's just anterior to the vermicellae, superior vermicellae, that is very important. You need to look at that. Excuse me. The next is a low-lying torcula and a tentorial herniation, because that really decides your approach, and we will get into that again. What is the relationship to the deep venous system? Because if it is deeper to the deep venous system, it could be a velum antepositum or a phacotentorial meningioma, epidermoid, pinealocytoma. If it is superior to that, it could be a splenial glioma. The infiltration of the tumor inferiorly into the cerebello-mesencephalic cistern. So here is a very important point, that an infratentorial supracerebral approach it's very difficult to access this part of the tumor, and this is very, very important here. The other thing is a lateral extension or a pure intra-third ventricular location needs to be looked at. And of course, CSF dissemination is another point that you need to look at. So let's talk about various approaches. You have this infratentorial supracerebral approach. You have this tumor, which is in the third ventricle coming into the quadrigeminal cistern here. And you can see on both sides and almost in the midline here. And so when you're looking at the position, what are the important considerations? One important consideration is it's not a sitting position as such. It is a sitting slouch position, so that the head is close to you feel. You can break the table here, and or you can actually rest your arm on the broken head of the table here. When you're performing flexion of the head, you must make sure the 2-finger rule is followed, where 2 fingers are just below the neck. You must try to have adequate flexion, and you can also bring the table forwards to make the tentorium horizontal. So the tentorium has an obliquity. So you try to make the tentorium horizontal by your position. You must have upper limb support so that there is no ulnar nerve palsy. You must make sure there is adequate venous return so that the lower limbs are also elevated up. And you must be in a situation where you have long instruments. The important thing is that when you're using a sitting position, there's a free flow of blood downward, so it doesn't pool up into your operative field. And there is no intervening brain in the trajectory. So this is a very, very useful approach. So when this is the suboccipital craniectomy, and this is the C1 arch. This is the superior portion. You can see the transverse sinus. You can see the occipital sinus in the center. And you cut the dura up to the level of the annular sinus, and then you cut it downwards here. And then you see the posterior part of the cerebellum and the cerebellum and the cisterna magna here. Now the important point is that the cerebellum the superior vermis is retracted downwards very gently. The important thing is not to go too much lateral when you're retracting the cerebellum. And the reason is that there are multiple veins leading from the superior cerebellar surface to the tentorium. So if you coagulate these veins, one is that there could be infarction of the superior cerebellar surface. But more important than that is the fact that the cerebellar upper surface goes on sagging. And as it goes on sagging, then more and more weight of the cerebellum rests on lesser number of veins. And if one of these veins snaps without your being able to control it, then the whole cerebellum can swell and the blood can obliterate the operative site. So this is the superior vermis, and you see that there is an obliquity of approach going to the, there is an arachnoid membrane there, and this is the obliquity of membrane, and you can see the venous system from the arachnoid membrane. So you see that when you're approaching it, the hands are pretty extended, and this is a pretty long approach to reach this midline. Then as you reach the midline, you see the arachnoid, and you will usually get a precentral cerebellar vein in the center, which you can shift to one side or the other. Remove the arachnoid, you can see the tumor here, and then you decompress the tumor till you see CSF there. And of course, we all know that there could be air embolism, there could be hemorrhage, because the patient has negative pressure of the veins or zero pressure. So whenever you making the patient supine again, there can be bleeding from veins. So you have to have a very meticulous hemostasis, and you have to remain dead in the midline. The second thing is when you are positioning a patient, you can have postural hypotension. So you have to alternately elevate the leg and then the head. And there can be a flexion myelopathy if you manipulate the neck too much. And of course, there is the surgeon fatigue because you're extending the arm, and shunt malfunction can be a possibility here because of pneumocephalus, because of blood going into the ventricular system. So we have this patient who had this posterior third ventricular tumor, And this is a small child here. You see the position. So you must keep 2 finger arms and keep it as close to yourself as possible. You see the vermis, and gently 1 or 2 midline veins can be coagulated, or just the arachnoid. Just by opening the arachnoid, you can reach this part just superior to the cerebellar surface. And then you see the superior vermis. You can gently dissect this. This is the obliquity is quite significant. So for the initial part of the approach, you will find that there is a very oblique approach, and then you see this white glistening arachnoid, and just behind the arachnoid you see the veins. You have the basal vein of Rosenthal and the vein of Galen in the center, and then you, as you are dissecting, you can see the precentral cerebellar. Then you shift it towards the side, but on most occasions you can actually coagulate it to get a dead midline approach to the tumor. So you can see the precentral, the cerebellar vein here, and then you clearly define it on both sides, and then you can see the tumor in the arachnoid just behind it. So you can clearly see the precentral. It's very important that you don't go, so you can see the basal vein of Rosenthal, the vein of Galen here. And therefore you must remember not to go too much on the sides, but remain in the center there. So just coagulating the precentral cerebellar vein. And dividing it. And then you see the tumor there. So there are multiple veins on the side. So this approach is very useful for a midline tumor, but it's not very useful for a tumor which is going towards the lateral aspect, number 1, because you can actually snap a vein and you won't be aware of it because of the negative pressure of the vein. And the other very important thing is that if the tumor is going too much inferiorly anterior to the anterior vermis, then it becomes difficult to manage. The important thing is not to try to remove the tumor completely, but to allow the tumor to gradually come into the midline until the entire tumor is removed, and you can see the CSF egressing from the third ventricle. Now you see this is the part of the tumor which is just anterior to the anterior vermis that becomes difficult to access using this approach. So therefore you must remember that if there is a tumor which is deep down and anterior to the vermis, it is much easier to look down from above rather than to look from below upwards. So gradually you decompress the tumor, and if it is soft, then it gives you adequate space. If it is cystic, it gives you a good space. And then in the end, you can see the CSF coming, and you can see right up to the foramen of Monro sometimes. You have the veins on the side, and you can see the CSF completely. And then after the tumor has been removed, you perform hemostasis. So there is a bit of Surgicel on the superior vermis just to protect it. And this is the post-operative image where you can see that there is a little bit of pneumocephalus because of the sitting position. The second is an occipital transtentorial approach in the quadrigeminal cistern. You see there is a epidermoid which is conforming to the cistern, posterior to the brainstem and the collicular plates, and it is also going quite high up. So when you're going and also coming low down here, so it's on the side, that's a contraindication. If it's too low down anterior to the anterior vermis, that's a contraindication. If it's too high, then it becomes difficult to access using an infratentorial supracerebellar approach, and therefore we used an above downwards approach, which is an occipital transtentorial approach. So what are the important indications that I would rather prefer to do it in a prone position with the head tilted towards myself. As a surgeon, I'd like to make the head tilted towards me. So the important thing is that this is the superior sagittal sinus here. This is the transverse sinus. This is the torcula. So the flap is a triangular flap. We don't go across the midline, just stay on the midline. And the important thing is that these burr holes on the torcula are a little higher than the torcula, but you must access the midline. So the burr holes here need not be made dead in the midline, but rather at the edge of the superior sagittal sinus here. And then you can make a square shape craniotomy here. When you tilt the head toward the same side, then the occipital lobe and the parietal lobe shifts. And it's very important to understand that the approach is in the interhemispheric plane, and not in the suboccipital plane. This is a very, very important point, that it is still intrahemispheric because there are no veins there, and never should one make the mistake of lifting up the occipital lobe, because this will cause homonymous heminopia. Now, the important thing here is that when you look at this point, you see that if the tumor is here, so you are going parallel to the straight sinus and going to the tentorial incisura, where you can work below the basal vein of Rosenthal and the vein of Galen, or you can work in the corridor between the basal vein of Rosenthal and the vein of Galen. And then by cutting parallel to the straight sinus and avoiding the venous lakes here, when you cut the tentorium, what you get is a significant amount of space here on the superior vermis, so you can remove the tumor from here. You can get an additional corridor by cutting the falx superior to the straight sinus. So if you cut the falx superior to the straight sinus, you can get an additional corridor. So you have two corridors here. One by cutting the tentorium here, which is of 2 layers, and the second is by cutting the falx, so you can go across the midline, you can go to the opposite side, and you can also go from superior inferior aspect to get to this part of the tumor. So, but you have to be careful here. Sometimes the tumor will be infiltrative and the vein will be in the center and the tumor will be on both sides. So in this situation, it might be a good idea to approach the tumor by 2 combined approaches. First going by an occipital transtentorial and then going by an infratentorial supracerebral approach, rather than by combining both occipital transtentorial approaches, because that can lead to bilateral homonymous heminopia and cause cortical blindness. So this is an important consideration in an infiltrated tumor with a vein of Galen right in the center of the tumor. So what are the operative steps? So this is the falx, this is the anterior aspect, this is the posterior aspect, this is the parietal lobe, the occipital lobe is here. So never put the retractors on the occipital lobe. Gentle retraction, which is gravity dependent retraction. So you can actually at some point remove the retractors here. And the most important thing here is to identify the straight sinus. That is your landmark. That is like your lighthouse, which is continuously guiding your approach. The next is to perform a coagulation parallel to the straight sinus on the tentorium. So this part is the tentorium, this part is the falx. So when you come like this, when you and there are hardly any veins that you see here. So you come parallel to the tentorium, parallel to the straight sinus here. And then once you reach this point, then you can actually cut in, give incision. So there you can see that this epidermoid can be completely seen from the 2 leaves of the tentorium here right up to the incisura. And the straight sinus, you can see the blue colored straight sinus here. You can clearly see the straight sinus here. Now, as you expand this corridor, you get more and more space below the straight sinus and below the basal vein of Rosenthal. So you can remove most of the epidermoid tumor here. And then you can see the superior part of the cerebellum. You can look anteriorly and you can see the ventricular system. The disadvantage of this approach is that the part of the tumor which is behind the ipsilateral wall of the lateral ventricle is difficult to access. But the contralateral wall, the opposite wall, will be easier to access when a tumor is becoming intraventricular from being in the corticospinal space. And the final picture that you see where the lobes are completely relaxed and you can actually see the entire surgical corridor there. Excuse me. So you see, this is the straight sinus. This is the occipital, parieto-occipital area. So you're giving the incision in the tent. We must remember that the tent has 2 layers and tentorium has 2 layers. And therefore you must coagulate and then cut gently from, and you can see that this straight sinus will always form your, direction. So this is the point of direction here. This is the straight sinus and you're cutting parallel to the straight sinus and away from it. Even if you're away from it, you can actually cut the tentorial margin superiorly and actually get a very good corridor, and you can retract both the margins and get a very good corridor there. This is inferior to the straight sinus and inferior to the vein of Galen and inferior to the basal vein of Rosenthal. Now, this is where the arachnoid is open and then the entire epidermoid can be removed. Now, the speciality of an epidermoid, it creates space for itself. So as you irrigate and as you go on dissecting, you get more and more space. You can go to the contralateral side. You can see the brainstem, you can see the ventricle, and you can actually try to remove the capsule. But you must remember one small thing with an epidermoid, that if there is a capsule which is densely adherent to the anterior brainstem and to the superior vermis of the cerebellum, it is much better to leave it there than to try to do a heroic job there. And there you see that after the surgery is over, you see that there is no, the actually occipital lobe is actually fallen from the falx there, and you can actually get a good corridor there. And this, of course, turned out to be an epidermoid. This is another very interesting case, and this was a large meningioma in the posterior third ventricular area. Now, whenever you're operating on a giant or a large meningioma, then an infratentorial supracerebellar approach is not a very good approach, because then you get tired, you're looking upwards, and if there is any bleeding, it is much better and much easier to stop bleeding from above downwards than to go from below upwards and try to stop the bleeding. And the other very important consideration while you are selecting the side of the approaches, you look at the displacement of the veins. And if the veins are displaced towards this side, you must try to go from this side. You must go from this side contralateral to the side of venous displacement. The other very important consideration is that please examine the patient clinically. And if there is homonymous hemianopia, then suppose if there is right homonymous hemianopia, then you go from the left side. If there is left homonymous hemianopia, then you go from the right side. And the very important consideration is because you do not want to cause cortical blindness in these patients. Now, most of these tumors can be either arising from the velum interpositum, or there could be focotentorial. And what is the difference between them? A velum interpositum meningioma will not have any adherence to the falx or the tentorium, whereas a velum interpositum focotentorial meningioma will have adhesions to the falx or the tentorium, and therefore this becomes difficult to remove. So you see that here there was a bulge, there was hydrocephalus. So first we did an external ventricular drain. Then of course the same way we cut the tent, also created a margin above on the falx. So we got two corridors here. We could remove a bit of tumor from here, and we could also remove a bit of tumor from above downwards, and we could decompress completely and remove it totally. So just to show you the video here. So just making a very small hole here just to put in an external ventricular drain. And this external ventricular drain is put into the trigone. It's not in the occipital horn, it's in the trigone, because occipital horn will only be opened when the ventricles are completely dilated. So you see, as you are draining CSF, you see that the brain is falling from the falx. So it gives you a very good corridor. This is anterior, this is posterior, and a gentle retraction. You can see the falx here, and there's a very gentle retraction here, which gets you to the intrahemispheric space. So you must remember it is intrahemispheric, and you're not lifting up the lobes. And you can see the tumor down below at the lower margin of the falx, and this is the inferior sagittal sinus that you see that you also need to coagulate here. So you see that the straight sinus, this is the straight sinus here, and what you need to do is, and this is the lesion that you see here. So the important thing is that gently create a corridor for yourself. And here I didn't need to cut the tent because the tumor had created space for itself. So I could initially decompress a significant amount of tumor before I went to cut the tentorium and the falx. So you can see the tumor clearly in the quadrijuvenal cistern and reaching up to the anterior brainstem. So now this is just dividing a few adhesions of the intrahemispheric area to the tumor, the arachnoidal plane, and this was a slightly vascular tumor, but it was reasonably soft and not too fibrous. So I could actually decompress it and then remove it completely. So this way you can actually go into the tumor, decompress it. But the important thing is that I knew beforehand that both the veins are shifted.
Sanjay, I think we need to wind up because we are running behind time.
Okay. So, just So you can just decompress the entire tumor and then you see the entire surgery here. So this is the post-operative view, and you can see that the veins are preserved and you have removed the tumor from this corridor. So the important thing is that you must be careful about the venous lakes. You must be careful about the tentorial incisura. You must understand that you're working between the veins. You must remember the tentorial obliquity and the homonymous hemianopia. Now, a very good approach is an anterior transcallosal transforaminal approach. And we have discussed part of it. So you can go through the corpus callosum into the lateral ventricle, and you can either follow a transforaminal or a subchoroidal approach to reach the posterior third ventricular tumor. And you can actually go to the corpus callosum here, go to the lateral ventricle, see the choroid plexus, then go subchoroidal into the third ventricle, shifting the vein of Galen and reach the tumor here. And another important thing is that an endoscopic approach is a very good approach. And you can do a simultaneous third ventriculostomy, and you can also access the tumor, take a biopsy. If it is a malignant tumor, which is very, very chemo or radio sensitive, then this is a very good approach, because first you do a third ventriculostomy so that the CSF does not kind of, the CSF is not obliterated by the blood of the, when you are taking a biopsy. And then you actually take a biopsy. And if it turns out to be radio sensitive and a chemosensitive tumor, you can actually remove it. The important thing is that when you're taking an endoscopic biopsy, you must remember that sometimes the biopsy is going to be negative, because you are taking a part of the ependyma. So you must understand that you must go deep into the tumor and actually take a biopsy from there. Sometimes when you're going through the endoscopic approach, it's not always hunky-dory, because here we try to remove an intraventricular dermoid, and there was this extensive chemical meningitis. And even after 5 years, this patient developed significant cognitive disturbances and actually became visually impaired. So sometimes, this can be a real disaster, as occurred in one of these cases. We must never forget that radiotherapy and radiosurgery are very good options for these tumors. So a biopsy and radiotherapy are, for these invasive tumors, are very, very good options. And for children less than 3 years and after surgery, chemotherapy is a very, very good option for tumors which are germinomatous tumor, non-germinomatous germ cell tumors, and for other malignant tumors like pinealoblastoma in this region. But once the last slide talks about the 5-year and the 10-year survival of tumors in this location. And this gives you a very good idea about how your surgical approach should be. So in a germinoma, there is a fantastic 5-year and a 10-year survival now. And you can understand that even if you've removed it partially with radiotherapy, you can do a very good job. Even with germinomas, with non-germinomatous germ cell tumors, you can have a fairly good 5-year and 10-year survival. Even germinomas with teratomas, a 10-year survival is less, but a 5-year survival is fairly present. A teratoma has a very good 5 and a 10-year survival, a benign teratoma, but a malignant teratoma has a 71% survival. But a malignant germ cell tumor, a choriocarcinoma, a yolk sac tumor, an embryonal carcinoma, no matter what modality of therapy you use, the survival, 5-year survival is dismal. And a pinealocytoma has a survival which is nearly as much as that of a germinoma. So your surgical strategy and extent of tumor removal can be retrospectively planned. I mean, you can plan using this table and you say, okay, can I go more aggressively in this tumor, or do I go less aggressively in this tumor, based on your 5-year and 10-year projected survival. Thank you very much for your kind attention.
Thank you, Dr. Sanjay. That was, as usual, it was a wonderful presentation. And you can stop sharing, Sanjay. As we are 20 minutes behind schedule, I think we can take one question which Dr. Suchanda has put up. She wants to know, where do you open the arachnoid? Because it remains very thick and sometimes it obscures the underlying veins.
Which approach are you? Infratentorial supracerebellar, right?
I presume that's what she's referring to.
Yeah. So usually, you know, the basal vein of Rosenthal's and the other veins will be quite laterally, and the precentral cerebellar vein will be in the center. So I would say an angle of about 30 to 45 degrees is the best angle to take when you are actually opening the record. Not in the midline, not dead lateral. Somewhere which is not right in the center, but a little 30 degrees off center on both sides.
Okay. So I'm sure there are plenty of questions. I do have plenty of questions to ask, but I think as we are behind schedule, I think we need to move on to the next lecture.
People can put the questions in the question and answer box, and Sanjay can keep answering them as they come along.
Answer that. Okay. Let's move on. Dilip, can you take over?
Yes, thank you, Muthukumar. Thanks, Sanjay. That was an excellent talk as usual. It gives me pleasure to call up another absolutely wonderful speaker, Dr. Sandip Chatterji, the Professor of Neurosurgery and Chairman of Neurosurgery at the Park Clinic at Kolkata. Personality in his own right, with varied interests which range from pediatric neurosurgery to wildlife. We would love to hear him talk about a non-neurosurgical topic, but today he's going to be talking about surgical approaches to tumors of the fourth ventricle. Sandip, over to you.
Sandeep, you're muted. You're muted.
Great. Now I've unmuted myself. Am I visible and audible now?
Yes.
Yeah, great. Thank you, Sridhar, for giving me this opportunity to talk in the midst of such great personalities. Let me just put my stopwatch on. I'm going to try and limit myself to the time allocated to me, not least of the reason for which is two. Number one, I do not belong to any of the major institutes that your preceding speakers belong to, and my experience is very modest compared to my predecessors. And secondly, the fourth ventricle is the only ventricle that you can actually reach very fast without resecting any brain or any white matter. So really, when you talk about, and also thirdly, I will limit myself to approaches to the fourth ventricle, and therefore will talk little about the pathologies. So what I'm going to talk to you about is based on our very modest experience of intraventricular tumors in the fourth ventricle. This is a series that one of our DNB PGTs did. So medulloblastomas like this, astrocytomas like this, ependymomas, which are somewhat less than medulloblastomas, and finally dorsal exophytic gliomas that protrude into the fourth ventricle. So the fourth ventricle, as I said, is one of the ventricles which you can access very easily through here, and that's the foramen of Magendie. The roof is, as you know, has two components, the superior medullary velum and the inferior medullary velum. And to get into the fourth ventricle, you have to go through one of these or go through this opening itself, which is a natural opening. The floor, of course, is much more dangerous, housing a lot of important structures. And by and large, this is an area which we tread with great caution. So fundamentally, if you have to get into the fourth ventricle, you have to go from here and enter through this area or go through the middle of the vermis. As I said, the fourth ventricle is a much easier ventricle to get into because it's exposed to the exterior without having to go through any major structure. And all you need to do is to retract these tonsils, elevate the uvula, and if at all, retract this part of the cerebellum, the biventral lobules. And there you are into the fourth ventricle. The only problem with the fourth ventricle, of course, is it doesn't look like that in real life. And there are these two vessels, the two picas, which stand in your way, and which are the two vessels that you need to look at very carefully before entering into the fourth ventricle. The two traditional approaches to the fourth ventricle are to go through the vermis, the so-called transvermian approach shown on this slide, or the so-called telovelar approach, which is to go through the area in between the two tonsils without resecting any of the vermis at all. When do we use which approach? Again, this is a matter of maybe personal choice, but for me, if there is a very extensive tumor extending from one side to the other, and that's one lateral recess of the fourth ventricle to the other lateral recess of the fourth ventricle, personally, I would prefer a transvermian approach because it gives you lateral exposure. If you have a tumor either in the midline or on one side and is going up, then the telovelar approach is clearly better for reasons which I will share with you just now. And if you have a lateral recess type of tumor, then the telovelar approach can be slightly modified, the so-called transcerebellomedullary approach, and that gives you excellent up and lateral exposure. So this is a very interesting paper, and I really find this an amazing paper, which looked at the area that you have exposed if you go through a transvermian approach. And if you just look at this slide, this is the only take-home message. That's the transvermian approach. So your angle of view is like that, as opposed to the telovelar, which is looking upwards. And the area you see with the transvermian approach is that much, with the telovelar approach is that much. And then if you take the C1 arch off and look from further below, you look further upwards, and that area that you can see is much more. So one of the corollaries of this has been that in the past, we used to not take out the posterior arch of C1, but increasingly, when we do a telovelar approach with large tumors extending down, I would not hesitate to take out the posterior arch of C1 because it gives you an excellent trajectory. And this is the trajectory that you see in the telovelar approach. And notice that you can see all the way into the aqueduct. Whereas with the transvermian approach, your view is much less oblique, a lot more transverse, and it's really difficult to see right up to the aqueduct with the transvermian approach. So this is just a comparison of the two approaches. In the interest of time, I'm going to skip over this, but just to share with you one important thing. That's your lateral limit of exposure with the transvermian approach. And remember that the trajectory is like this. It does not take you right up to the aqueduct, whereas with a telovelar approach, the trajectory can be a much, much higher. So how do we do this operation? Of course, there's the usual debate about whether we do this prone or sitting. For us, it depends on the tumor. And I think really it depends whether you're doing a fourth ventricular tumor or a brainstem tumor. If you're doing a tumor, as I said, with a very far lateral extension to one side, and whether you're doing a tumor which is extending upwards into the aqueduct. It depends on the age. Children, in our experience, tolerate a sitting position much better than their adult counterparts. Hemodynamic instability is much less with children. And therefore, in my practice, the only time we would use sitting position is in fact in children, and I rarely use it in adults. And of course, it depends on the surgeon, with apologies to Professor Manoj Bhattacharya, who modeled for this particular slide. And it depends on the surgeon's habit, whether he likes to do it sitting or standing. And finally, you have to be comfortable in whichever approach you choose. This is my friend, Professor Hinosa from Madrid, who lent me this slide of a young man who started to do a microscopic procedure in the posterior fossa with the patient in a sitting position, found ultimately that the only way he could visualize the tumor is in this position, and that's not really what you want to do. So it depends on the tumor, it depends on your patient, it depends on your surgical preference. And if you look at this paper published 30 years ago, as time has gone on, people have moved from sitting to more prone positions. And we use both. As I said, he is a child, and we certainly use it in children a lot in the sitting posture, whereas this is a teenager where we have done it in the prone position. Again, you know very well that the main problem of a sitting position is the low venous pressure. The head fixation is extremely important. The legs have to be elevated, and we use anti-shock trousers. In the prone position, they're much easier to position, but of course you have to make sure there's no thoracic compression. And the very important thing is head fixation to avoid any compression on the eye. So is there a best position? I dare say that there isn't, because it depends on anatomical landmarks. You have complications of a sitting position, you can get air embolism, etc. And this is a nice article which suggests that, in fact, the sitting position is the best position for children, but this is, in fact, very debatable. What is not debatable is that these are absolute contraindications to a sitting position. A VA shunt, a right atrial pressure in a child, which is excess of left atrial pressure, a patent foramen ovale, and a stroke when upright and awake are definitely absolute indications. So finally, a best position depends on the the surgeon's choice. What about EVD when we are operating on posterior fossa tumors? I'm not going to go into the controversy. I'm just going to tell you that if you have dilated ventricles, which tumors of this size, which we're now encountering quite a lot in the pandemic, then it is our practice to put in an EVD routinely, turn the patient around, do the posterior fossa tumor, keep the EVD clamped for 48 hours, and if all's well, we take it out after 48 hours. Do you use a straight incision? Yes. Do we use a Y-shaped top? Now, this is a Y-shaped muscle cut, was first introduced to me by Professor Harold Hoffman when I was his fellow. And this way, Harold reckoned, and I think he's right, that although there is a theory you might devascularize this bit of muscle, this muscle can be sutured later on and it prevents CSF leak from the top of the wound. So we generally use a V. Do we remove the posterior arch of C1? I've already told you, when we use a telovelar approach, that is exactly what we do. What about craniotomy versus craniectomy? Today, increasingly, and these are children, we would use a craniotomy and put the bone flap back at the end of the procedure. The craniotomy is tailored, so you site it depending on where your tumor is. We do not routinely include C1, but anytime that the tumor is low, and I worry about getting to the bottom of the tumor, I would not hesitate to take off the posterior arch of C1. And the reason for that, I'll come to in a minute. This is the dural opening is pretty standard. We generally stick to this Y-shaped opening. The sinuses is one of the things, particularly in children, that you have to be aware of. And I somehow feel that you can tackle them from below upwards better than from above below. So although we make the Y-shaped opening by opening the dura on both sides, I like to open the dura in the middle, get that sinus under control, and then work upwards in a way which, in fact, Manas has described before. So that's the dural opening, and then you get to the arachnoid. We use a retractor initially to be able, this is in a telovelar approach, to be able to move the tonsils gently, move the uvular up. I'll show you this a little later. We use the intraoperative neuromonitoring, and I'll come to that in a minute, and then that can get you very easily. And when you have a tumor of this size, it's quite easy to reach the tumor and do a complete resection. This is a child with a much smaller tumor. The smaller tumors, in fact, are technically quite often more challenging. This is a dorsal exophytic glioma glowing into the brain, into the fourth ventricle. We use a lot of intraoperative monitoring. This is just a photograph of this child, just show you the amount of wire that's dangling all over the place. And we use BAER, we use MMEPs. We also use, we have our patients like this in transparent drapes, so I can actually see which part is twitching as the neurophysiologist looks at the monitor. We routinely monitor the facial nerve. We also monitor the tongue, so that when you're having a tumor like this, which is a dorsal exophytic glioma, you make sure you don't tread into the hypoglossal triangle. Very easy to record. MEPs from the tongue. And then this is just, and I'll skip this. This is just what we routinely do before and after tumor resection to look at this. Just a little bit about the technicalities. It's very important to open up the arachnoid. The first thing that we like to look at after opening the arachnoid is to identify the pica, because that's really your enemy here. And once you can identify the pica very early in the procedure, it makes life a lot easier. And this is, in fact, the two tonsils. That's the medulla. Those are the cerebellar hemispheres. And then gradually we open up what I like to call the telovelar tonsillar fissure. because that's what it really is. It's the telovelar tonsillar fissure that goes right in, and it's very easy to do that. This is how we like to do it, very gently, without a retractor as far as we can. And then we open up the cerebellomedullary fissures. I'll just speed that up in the interest of time. And then, of course, you can enter into the fourth ventricle and see your tumor. So that's really the trajectory. And then if you widen the telovelar tonsillar axis like so, really you really need to bipolar some of these spica branches that come very close to the roof of the fourth ventricle, and they're really pretty harmless, these little branches that go to the roof, and you can remove them with impunity to give you adequate space. We do not like to use a retractor, as I said, as far as possible. And this is just to show you that, again, while you widen this fissure, and then that's the tumor which is exposed. You will notice there are strip cottons, but there are no retractors, and that's what it looks like at the end. I'll come back to that in a minute. So this is the patient pre-op, that's the post-op imaging, and you can really do a fairly total removal of these tumors. The other sort of tumor that protrudes often into the fourth ventricle are these, the so-called cervicomedullary junction tumors, and our approach to them is to do 2 strips. We do a laminoplasty like that, we do a craniotomy, and then it gives you access beautifully into this tumor, which is going right into the fourth ventricle. Again, it's a lot easier to do than it looks, and you can remove the whole thing. That's what it looks like. That's the pre-op, that's the post-op imaging. And you can remove this completely from the fourth ventricle. What are the adjuncts you use when you approach tumors into the fourth ventricle? Well, one of them is an ultrasonic aspirator. And I'm telling you this because increasingly we've been using less and less of ultrasonic aspirators with time. This is also a telovelar approach. You can see the tumor. And this is a very old video. This is a time when we used to do use a lot of ultrasonic suction. Now, of course, I think that most of these can be removed by just using suction devices. And this is an example of a tumor where we divide all around, and then we use the ultrasonic aspirator to take the last bit of the tumor out. This was also a time when I used to do these from above downwards. So I would try to get to the top of the tumor, look at the aqueduct, and then gradually bring the tumor down. This is something that I have completely changed. And I changed it after I caused bleeding in a patient where doing this procedure, and the patient had no hydrocephalus, and post-operatively the blood went into the third ventricle and the patient developed hydrocephalus. So I have stopped doing this from above downwards and would now do them routinely from below upwards, and I'll just share with you the reason why. So tumors like this, again, I would routinely go down from down upwards. Just to tell you a little bit, we do, for tumors like this is another dorsal exophytic tumor, we would do brainstem mapping, and that is, again, outside the purview of this talk, but just to show you, it's quite easy to map the brainstem when you try and resect a tumor like this, and I'm just going to skip this again in the interest of time. But this is what the tumor looks like, and of course these tumors present very nicely and lend themselves to very complete removal. So if you have a tumor like this, which is extending in both directions, this is one that I would use a transvermian approach as opposed to a telovelar approach, because then it gives you access from one side to the other. You can see the whole tumor and you can take it out much more easily. And I'll just skip the video again in the interest of time. So this is another one. This was in fact an ependymoma. This is an ependymoma, but we've just operated on, I think about 10 days ago, with a child who came with hydrocephalus and a tumor like this. Now, this is something that has changed in the days gone by. We would do an EBD and do the tumor. This child came untested, so we ended up doing a shunt, getting a COVID PCR, and only after it was negative, we went in and did the surgery. I'm not going to again go through the whole video in the interest of time. Here is one that we removed the You will notice we use a hand drill because we're not allowed to use high-speed apparatus now. And just to show you again, a Y-shaped opening of the dura. And the first step is to get to that bottom of the fourth ventricle and identify the plane between the fourth ventricle and the tumor. That allows us then to work on the tumor gradually, and we are able to lift this tumor up. And as I said, more and more, I do not do it from above downwards. I always do it from below. And that is why with the telovelar approach, I often would take off the posterior arch of C1. Just one, that's the post-op imaging. This was an ependymoma. We have a small little residue, but with ependymomas, I have to say, my tendency is to be a lot less radical. Here's one reason, and I'm going to end with this because I need to show you disasters as well, why we would advocate going from below downward. This is a small child with a medulloblastoma that was horrendously vascular. And when you have a tumor like this, the only way you can stop bleeding, and remember, this is a child who's 2.5 years old, it's quite difficult to make sure you don't have too much bleeding. Then you have to do everything to try and take the tumor out as fast as you can. And I'm just sharing with you this because this is one of my most untidy procedures on a medulloblastoma. This can happen in a small child where the tumor is very aggressive and vascular. And I'm just going to share with you what then we ended up trying to take, the only way you can stop the bleeding is to take the whole tumor out. And that again, we resorted to the ultrasonic aspirator, quick removal. That's the only way you can stop the bleeding in a very, very vascular tumor like this in a very small child. And just to show you, the end of the procedure is quite happening when you have the aqueduct visible and you can see CSF pouring out from there. So just the take-home points: plan the position to match the patient and the pathology, but work what is most convenient to you. We prefer craniotomies. The telovelar versus transvermian approach, I just told you. If you want to go up vertically, midline, telovelar is best. If you have very extensive tumors on both sides, particularly in ependymomas, often the transvermian approach is necessary. I always advocate working from below upwards, identifying the floor and roof of the fourth ventricle before proceeding up and identifying the picas. And of course, at the end, look for CSF coming down the aqueduct. We routinely close the dura if we can, and we also put back the craniotomy flap. Thank you very much. And I'm sorry, I think I've overstretched my talk by 4 minutes.
Thank you, Sandip. That was a very nice practical demonstration of accessing the fourth ventricle and the techniques to remove tumors that you are likely to encounter within them. So if Sridhar and time permits, we can have a question if any of the panelists, or there are no questions as of now in the chat box, though there are comments commending your presentation. But
Can
Dr. Muthukumar?
Just a couple of questions, maybe.
Yeah.
Just a question. One question to Sandip. You talked about dissecting from above and from below. And I think the reason you are worried is the blood moves into the, through the aqueduct into the third ventricle, and then the patient postoperatively develops hydrocephalus. Am I right?
Yes, that is one of the reasons. The other reason, of course, that I like to go from below upwards is it helps you identify the fourth ventricular anatomy early in the operation. And you know where the picas are, you know where the fourth ventricle is. As I showed you, I put a little cottonoid in the fourth ventricle, and I know the interface between the tumor and the fourth ventricle. Much easier when I work from below upwards than from above below.
That's right.
So 2 reasons.
I heard, I don't know who gave that talk, but somebody recently gave a talk where they said that they keep a gel foam piece at the level of the aqueduct to prevent the blood from the rest of the tumor going in, and then remove it at the end of surgery. Does anybody do that in the panel?
No.
I definitely do.
Dr. Majumdar is presenting on that he keeps it because he does it from
I was going to mention his name, but yeah, he said that Dattatra was presenting this, and he said that he likes to go always from above downwards. In fact, both Manas and I reacted in a similar way to that talk and said maybe we're doing it wrong because we go from below upwards.
I think
he said that he puts the gel foam to prevent the blood going into the aqueduct.
But I think the majority of surgeons would go from below because the natural tendency of surgery would be to go from below above, following the floor of the fourth ventricle.
And your telovelar approach is actually tailored for you to go from below upwards and not the other way around.
So the issue of blood going into the third ventricle through the aqueduct arises only in the prone position, not in the sitting position.
Yes.
This question of this is sometimes referred to as the snow globe effect, because the blood that goes inside, the clot comes and settles on the aqueduct, top of the aqueduct, and post-operatively patient develops hydrocephalus just like a snow globe. I think that occurs only in the prone position, not in the sitting position. So
absolutely,
I am comfortable going from below upwards. I am certainly comfortable, whether it's telovelar or transfermium, I am comfortable going from below upwards.
Sandip, there is a question to you asking whether the CUSA affects intraoperative monitoring, neuromonitoring.
Yes, it does. It definitely does. And we've seen that, and that's one of the reasons why we use it less and less. Now, definitely we've seen that the CUSA affects intraoperative neuromonitoring.
So would somebody like to wrap up?
Manas, would you like to wrap up?
No, I'll request Dr. Sridhar to wrap up.
No, you do the wrapping up, and then there'll be a few comments. Yeah, Manas, please.
No, means already we're late. No, means everything was means all parts of the ventricle was covered, starting from above, lateral ventricle. Dr. Mathew, it was a very good educative lecture for all of us, not only the residents. I picked up many new points from each lecture. From Dr. Mathew's lecture of how to decide on, he made it simplified that the ventricular puncture and surgery are similar, so you don't have to get confused. And Dr. Krishna Prabhu emphasized on microscopic surgery, as he told that he never likes endoscopic surgery. And we had Dr. Watanabe telling that endoscopic surgery is the way to go. So as I told you that in Japan, they are only allowed either microscope or endoscope. And that is why they have become experts in endoscopic surgery, because they're not allowed to use a microscope. So his results are as good as microscopic surgery. And Dr. Sanjay Behari has published many articles on approaching the posterior third ventricular tumors. The best slide was the last slide, where he emphasizes that the aggressiveness of approach depends on what we expect radiologically, the pathology. If you expect a low-grade pathology or a better outcome, one has to be aggressive and go for total excision. And Dr. Sandip Chatterji, as usual, had an excellent demonstration of the approaches. And I had not read that comparison of telovelar versus transvermian. I was thinking transvermian will give a better access to aqueduct, but then he presented that it was the telovelar gives a better access to aqueduct. Thank you, Dr. Sandip. And with these few comments, I'd like Dr. Sridhar to give his comments.
So, all that I want to say is I want to thank all of you who have spent your time and educated all of us, me included. So thank Professor Muthukumar, Professor Dilip Panickar, Professor Manas, and then the speakers, starting from Professor Mathew Abraham, Professor Krishna Prabhu, Professor Watanabe, Professor Sanjay Behari, and Professor Sandip Chatterji. So thanks a lot to all of you. I think everybody has enjoyed this show, and I hope that we will continue to have even the next Tumor Thursday, which is going to be on cellular, supracellular, a very good. I must say that the participation has been extraordinary from the delegates. So thank the delegates as well who have come in. Till about 5 minutes ago, there were more than 120 participants looking in, and there's been a lot of active participation, and the response, what they're giving in the chat box itself is awesome. So thank all of you. I must thank Baxter and I think Mr. Ajay. Would you like to say a word? Just a word.
Yeah, so I'll not take much time because it's already late. All I would like to say is that thanks, Dr. Sridhar, for giving us this wonderful opportunity. I think we also learned a lot as the people in the audience. So looking forward to have such a great partnership in the future as well. So count us in all your future endeavors. Thank you.
So I think the good thing is that this has not been only, we have not had people only from India, but we've had people from all over the world coming in, right from Europe to Japan and Far East. So I think this has been a wonderful learning experience. I once again would like to just share that. So this our Tumour Thursdays is going to continue next month on the 8th of October, and that will be, this is this month's Tumour Thursday session 2. So session 3 will be next month. And then just once again, a reminder that we are going to have the Asian Congress of Neurological Surgeons, which is going to be a virtual international conference in December, because Sandip couldn't hold his conference. We thought we'll do something interesting. So thank you all very much, and see you all very soon in another platform. So please, everybody, share your feedback. I think there has been a link which has been given to share your feedback. So please share your feedback. If there are any suggestions, we would be happy to incorporate those suggestions to make the learning experience even better. Thank you so much. Thank you so much.
Thank you, sir. Good night.
Thank you, sir. Thank you so much.
Should we have a group photograph before we all leave? Yeah? Is everybody in, or somebody is gone away? No, I think
Dr. Watanabe, can be a little closer to the
camera? Can you just bring your face closer in?
Yeah, thank you.
Yeah, can we have a
one smile, please?
And everybody smile, please.
I've taken the screenshot.
Oh, great!
I'll share that. I'll share that right away, sir.
Right.
In a few moments.
So thank you all so much. Thank you. Bye bye. Have a great night.
Bye.
Yes, sir.
Night.
Bye.